Uh, Dr. Kodlu needs no introduction. He is the Honorary Secretary of Karnataka Ophthalmic Society, a very prolific surgeon, and he is a great. He has been doing great work in presbyopic LASIK surgery, and he is also the member scientific committee of the All India Ophthalmic Society. And he is the director of the Prasad Netralaya, and is a group of hospital situated in Udupi, and he is chairman Vision Committee, Government of Karnataka. So may I request Dr. Kodlu to go ahead for your presentation.
Thank you, Dr. Nagendra Prasad. So I'll try to finish within my time. So there is some, even though I loaded my presentation in a preview room, I think only Hall K is having some trouble with the transmission. So they uploaded and it's ready. Just half a minute. Thank you, sir. Pause. This is my financial disclosure. So I think, as you all know, that nowadays laser-based corneal refractive surgery become more and more popular. But you need to keep eye on, especially when you're treating high myopia or even thin corneas. Definitely, always there is a chances of ectasia will be there. So an implantable posterior chamber phakic intraocular lens was developed to rectify some such disadvantage and very effective, especially when you are correcting moderate to high emmetropia. So also, in addition, this procedure is particularly reversible, and you can reverse this procedure whenever you can expect some unexpected refractive changes can occur with the laser-based refractive procedure. So these are the type of posterior chamber phakic IOL available in the market. I think for coming to the type of material, I think Star ICL made up of a unique material called Collamer, and nowadays most of our Indian companies has come with from the material hydrophilic acrylic. I think one from IOCare, from Biotech, and even from Appasamy also, but no financial interest in any of these companies. So why Vision ICL is ideal? Because excellent quality of vision, predictable and safe, and location of implantation and the type of material used. So the material what they used in ICL is a collagen, which is a hemacopolymer, which is excellent biocompatibility, gives a quite high excellent transmission and a low reflection pattern, very flexible. This is the new design model from ICL. So nowadays, I think since last couple of years, they have come with the central hole case aqua port that eliminates you, and you need not have to do any peripheral iridectomy. Of course, because of this, it improves the aqueous humor perfusion on the anterior surface of the crystalline lens, which may prevent even further formation of the cataract also. Even they claim that even there is a reduced endothelial cell loss. Up to the location of these lenses, actually this is far from the endothelium. Of course, excellent cosmosis. The one important point I always tell, which is these lenses are which is close to the nodal point of the eye. So you get a better vision. Whatever the vision you promise, you get better vision because of these lenses are placed close to the nodal point of the eye. Gain in retinal image and a greater effective optical zone. It allows the crystalline lens to retain its function, as may possibly protect against any of the vitreoretina effects of clear lens extraction. So how to achieve an ideal phakic IOL? Main thing is pre-operative evaluation. Second one is perfect loading and intraocular insertion of these lenses. Though pre-op evaluation, like any other refractive surgery, the key is horizontal visible iris diameter. How you have to do according to US FDA by help of a surgical calipers. I think you can cross check with the op scan. So what I do in my practice, I check with the digital calipers, then once again I cross check with the manual ruler. So ideally the ACD should be around 3 mm. And a thorough assessment of the whole antechamber is also very important, not only in the central depth, you need to see in the periphery also. This is how you mark, especially when you are implanting the toric intraocular lens. So pre-operative procedure, adequate dilatation of the pupil, very important. Always I avoid the cyclopentolate. Minimum dilatation has to be around 8 mm. Of course, dilate with the tropicamide or with the phenylephrine, and can do it under topical anesthesia. So this is very important. Loading of the ICL, I think set up a loading tray with the necessary instrument and check that you have kept it everything in place. So first is place the foam tip applicator in the lens bottle so that it will be little bit softens and it prevent any damage to the lens. Then in the second step, you take cartridge in your left hand. First you take saline, you fill in the cartridge, then followed by some amount of viscoelastic that prevent the inadvertent damage to the lens. Then remove the ICL from the bottle. Each step is very, very important. Roll the ICL to the applicator tip, draw it till the mouth, then always try to avoid the forceps. Placing ICL on the cartridge, always when you're placing, you should look for the marking at the right bottom and the left top, and always with the help of broad side of the applicator, you try to push little bit like this, then you rotate to place the ICL into the groove. This is very, very important. Otherwise, you may struggle to do this step, you may take longer time, especially for this particular step. Then drawing the ICL into the position. This is the most important step of ICL loading. I think you have to keep your mind cool. This will be done with the help of a special forceps, which is you can get from the company. So the special forceps which is angled upwards, you need to introduce through the tip of the cartridge. Introduce, now hold the ICL. Once you hold the ICL, you hold it firmly. When you're pulling, pull the cartridge, not the forceps. Do not turn your hand either side. This is very, very important. Then fix the plunger. This is the simplest of all these steps. I think in this, how you are fixing in IOL surgery, same way you can place the cartridge with the ICL and you can lock it. Then you can push a little bit so that just to see the smooth movement of the ICL. Then up to the incision, I think up to the paracentesis, depending upon the surgeon's comfortability. I always do a single paracentesis. If you are a right hand side, right eye 4 to 5 o'clock, and for left eye you need to do a paracentesis at around 10 to 11 o'clock, which is always when you're doing, try to do an angled away. And coming to the corneal entry, I think wound size, I think you have to do around 3.2 mm. Once you do the paracentesis, put a sufficient amount of viscoelastic. Even the company won't advise that, but always I put a sufficient amount of viscoelastic so that you'll have a very much formed anterior chamber. So when you are entry with the 3.2, then when you're taking out little bit, you can extend so that it will be around 3.3, so that you will have a very easy insertion. Then up to the injection, so place the tip of the injector within the anterior chamber. Make sure that the visco will be there inside. Always you should stay shallow. Inject the ICL with a sort of a very smooth jerks. Once it's opening up, you need to look for the marked haptic opening on the right side. This is very, very important. When you keep, if the marked haptic opening on the right side, that means you are injected the ICL in the proper place, proper plane only, then you can place it over the iris. If you won't see that marked haptic opening on the right side, that means you have injected upside down, then you have to remove the ICL. Once again you have to reload. Once if you inject it properly, then I think you can place the implantable columnar lens over the iris. Yes. So this is the important step, tucking. So from the paracentesis, I think you can put some amount of viscoelastic with the help of a special instrument provided by the company. It's called tucker. Always hold the far tip of the haptic. Try to tuck and flush under the iris. Then you can use the main wounds, especially if you want to tuck the trailing haptic. Once you tucked it inside, once you put it inside, then always you should look for a round pupil. Then this is also very important thing, visco removal. I always do it with the Simcoe cannula, and I always stay within the anterior chamber at least a period of 4 minutes, so that you should able to take out most of the visco out of the eye. You can even tap gently over the iris or the haptic, so that in the end you will not be leaving any of the visco inside. So post-operative day 1, I think you should look for the vault, very important. Ideal vault should be half a corneal thickness to 1.5 corneal thickness. So of course, always you should vault. Sometimes vault values may vary because depending upon the light condition, accommodation, and unit used to perform the measurement. But when there is a lower than the ideal vaulting, always you should check for the central and the peripheral space between the ICL and the lens. If the separation is uniform, one can comfortably follow the patient. You can call them for regular follow-up. Whenever you feel that there is a higher vault, always you should look for IOP, iridocorneal angle, pupil dynamics. Always deeper and larger eyes, sometimes they can tolerate a higher vault than the lower vault. So what should be the expectation after the ideal phakic IOL? Mainly quality of vision, quality of life, and excellent efficacy and predictability. Always these are very good in higher order aberration. You improve the contrast sensitivity and night vision. Different studies given by the few of the person, especially by Kami et al. He proved that it is much better than wavefront guided LASIK, and most of the studies has been compared with the laser refractive procedure. They claim that overall quality of vision, contrast sensitivity, dry eye related symptoms, glare symptoms are much better with these ICLs. So of course, same studies with definitely gives rise to ICL is much better. So which one to choose? Current available data, I think Star Surgical is the best one. Even Indian lenses are to be promising, long-term results are waited. So take home message, phakic IOLs are certainly an exciting technology in our surgical armamentarium. Probably one of the most simple, I think, surgery, most tensing to. Phakic IOLs gives you the most happiest patient. Quality of vision is always better than promised. Thank you.
Thank you very much, Dr. Nagarendran. Yes, sir. Questions?
Just one question.
Yes, sir.
What do you advise post-operatively, what to do or not to do after the surgery and all that?
Sir?
What do you advise post-operatively?
Post-operative
What can the
advice to
patient do or not do?
No, see for vault and the post-op medication. How you put in cataract? I think same like 4 times a day, steroids for a week, then you can taper it to 2 times, then once a day. 3 weeks I put them steroid drops.
Do you advise them to don't rub the eye for the longer?
Yeah, of course. Same like cataract surgery, same advice you can give them.
Have you had any complications, doctor?
ICL surgery, I think I have done more than 500 cases. So far, I think 3 patients when I injected, it was upside down.
Not operative, late post-op?
I think touch wood, so far none of my patients develop cataract. The key is white to white measurement. If you do so well this white to white measurement, there is no chance that my 6 years follow-up patients are coming, absolutely no cataract at all.
And glaucoma?
None of my patients. Once again, key is white to white measurement. I think you need to repeat that with digital calipers. Once again, compare with the handheld ruler. I think there should not be any problem.
Any other